Welcome to PharmaDocs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Hey, John, how you doing?
Hey, Jay. Great.
Good.
And you?
Good. We finally, it hasn't rained in a while, which is nice. We need the break. It was a little bit sunny, although it's getting pretty. It was pretty foggy this morning when I woke up, and I'm not even close to the ocean. So
how about the snow?
There's still tons of snow.
Tons of snow.
Yeah. Are you still planning to go to Utah to ski?
I'd like to, and then I found out that Deer Valley is closing April 23rd.
Yeah,
it seems like I've got something every weekend to attend, Jay. And so that's why I was looking at, I think we might be able to get a trip in, and we were looking at the last weekend of April, and then I'm on their email list, and they say, no, we're shutting
April 23rd.
the slopes down.
Yeah. Snowbird's going to be open, I think, to middle of May. And Mammoth, they're saying they're going to be open through the 4th of July.
Oh my gosh. That's just hard to believe.
It's crazy. It'd be nice if we get weather like this next year.
It is so hot down here at 4th of July. I mean, you just step out of your car and you're immediately wet.
Yeah.
All right. It's just that
a little more humid where you are than where I am.
Oh, absolutely.
Yeah.
All right. What we got on the show this week?
Well, I was thinking, we're preparing all our material for the webcast.
Yes.
And what I've noticed lately is that there are a whole lot more drugs approved by the FDA that are for rare diseases, what they call orphan drugs. And so
I saw that.
Yeah. So how many rare diseases do you think there are that have been documented?
Gosh, Jay, I'd probably guess maybe 2,000 or 3,000.
It's actually like 7,000.
Wow.
7,000. Yeah.
7,000. Now, what's the criteria of, quote, a rare disease?
So anything that affects less than 200,000 people is considered a rare disease. And that's throughout the world.
That was my next question. Is it the United States or, okay, so the world?
Yeah.
Right.
But in the US, if you combine all the people who have these rare diseases, it's about 25 million Americans.
Gosh, that's almost 10% of the population.
Yeah. And so I was wondering, why are we seeing this explosion of orphan drugs that I don't recall seeing this many new drugs for rare diseases in a long time. So, as you know, developing a new drug is very expensive. I mean, there's research, development, it's got to go through testing. And if you
it's also time consuming as
very
well.
time consuming.
I mean, we're talking about decades.
Yeah. So the cost could be like astronomical. And then if you have, let's say, 2,000 people who have this disease, you spend all this money on research and development and testing, and you don't have that many people to sell to. And so that was one of the big issues, is that these drug companies had no incentive to work on drugs for orphan diseases. So it turns out way back in 1983, Congress passed the Orphan Drug Act. And what that did was it incentivized these drug companies to do research and start developing more orphan drugs.
Yes.
And they give them some financial support, but the big thing they do is they do more of a fast track of approval of the drug. I think we've mentioned on a couple of these drugs that it's temporary approval based on a couple studies, and that further approval will be based on further studies.
Right.
And so they have what's called fast track. So if let's say it's a drug that meets an unmet medical need,
right?
If it's shown to be significantly better than what's on the market right now, if it's a new class of drugs that there's nothing like it, they're considered like breakthrough drugs. Or in addition to having a superior outcome, if it's found to have a lot fewer side effects,
right?
Then that qualifies it for this fast track approval with kind of an accelerated approval and preferential treatment in a sense, priority review.
And
Yeah.
you know, another thing too with big pharma, Jay, yeah, it takes that when they submit for the patent, they get 17 years, and all that 17 also includes all the research and development, the clinical trials they have to go through, and it may
Yeah.
take them 12 years to get to market. They only have 5 years of brand protection.
Wow.
Then it goes generic.
Yeah. And maybe for these orphan drugs, they can hold on to the patent for a little bit longer. But so before 1983, before the Orphan Drug Act, there were only 38 orphan drugs on the market. Only 38. Now there are well over 600. Another thing that the Orphan Drug Act allowed them to do was to try to, charge for what it costs them to develop these drugs. And a lot of these drugs can be cost like $50,000 or more a year. Fortunately, about 2/3 of insurance companies will pay for these drugs. And so for those who have rare diseases, that's kind of a ray of hope. And we're going to talk about a couple of those new drugs today.
Jay, just think about, right now we're seeing in dentistry a lot, the introduction of AI, artificial intelligence. Just think about when they apply AI into pharmacology and new medications and the development of new drugs. I can't wait to see the explosion of drugs, because right now you and I know this. We have so many new medications coming out. Wait till that segment of our life happens as well.
Yeah, for sure.
So Jay, before we get into our drugs, I like to touch base, because anytime we have something that I or you believe is significant that occurred in dentistry, we like to present it.
Yeah.
Just this past week, from one of the major news sources with dentistry, was the report, Jay, of 2 teenagers getting their wisdom teeth removed and having anaphylaxis reactions.
Yeah, I read that.
And both these, none of these, neither patient was related, but what was a common denominator was the fact that both of them were on a topical gel for their acne. One during the surgery was given IV clindamycin. Then anaphylaxis occurred. The second, at the end of surgery, was given clindamycin and anaphylaxis occurred. Okay. So, you and I have talked about both in the DOMES video and on our patient dies segment as well. It just won't happen to me. All right.
Yeah.
And the best thing
famous last words.
Yeah. I keep telling everybody, just look at it like a medical emergency will happen in my office.
Yeah.
You'll be a better clinician, a better practitioner. Yeah. You'll be prepared and ready. And the interesting thing about this, Jay, they said this is the first, since we're talking about first in class or orphan drugs, first in this or that, this is the first time this has ever been reported. And I like to read something from that article. It said, the bottom line, what we believe is happening here is the first exposure via the skin, so the topical gel was applied for acne, prepared the immune response to produce the hypersensitivity reaction to the potentially hazardous allergen once it finds its way inside the body. So, Jay, what that means is that the gel sensitized these patients, and then the antigen was introduced, whether it be IV or oral.
Yeah. I wonder if there's a similar, there must be a similar antigen between the topical acne gel and the clindamycin.
Who knows?
Yeah.
But I'm telling all of
our
listeners, again, guess what? What do Jay and I always talk about? Get a great medical history. All right. So, hey, are you taking anything for acne? Yes, I'm on a topical gel. Just keep that in the back of your mind that if you prescribe something, I don't know if the culprit will always be clindamycin or could it be any antibiotic. But the author said the incident of this is anywhere from 1 to 10,000 to 1 to 20,000 individuals. And the consequences can be severe and require instant intervention.
Yeah, something else to look out for. Put on your radar is that
anaphylaxis is one of those
'Cause
medical emergencies, Jay. I call 3 minutes to live.
yeah,
Right?
yeah,
You've
because
got
we all have patients who come in for their wisdom teeth that have used topical acne medications.
That's right.
Yeah,
That's exactly right. So everybody just keep that in mind.
yeah, yeah, and it can happen. It probably can happen with the clindamycin given orally too, not necessarily IV.
All right. Are you having some technical difficulties? You're lagging behind.
Yeah, it seems like it, and I'm plugged into the internet.
Okay. Well,
Yeah,
I hear
you
you
were
loud and
lagging
clear.
you were lagging for a minute too. Let's see.
All right. I
Let's see
am
what it
plugged
says.
in also.
It says, uh-oh. It says I'm connected through Ethernet. Yeah. Okay.
All right, keep rolling.
So it must be spectrum in my area that's causing all this.
Okay.
Yeah. So the first drug we're going to talk about, let me crank this up here, is, there we are. Whoops, wrong button. Ah, there we are. Now I got the right one. Well, you wanted to mention this too, again, which we've mentioned before about just to remind people that all of our patients coming in, or a lot of our patients coming in now, are living longer. They're on more medications, and those things put them at increased risk for having adverse drug reactions.
Jay, that top line, last week, the patients I saw, I'm telling you, the majority of patients, minimal, probably 8 to 10 medications. Okay.
Yeah. Oh yeah. I've got patients like that too. It's
the
amazing
majority of my patients last week. Okay.
Yeah.
All right. It's amazing. All right.
Yeah.
These newer medications have, a greater effect on our patients, improving their lives, their quality of their lives. But
in the past, the patients would succumb to their disease because these medications weren't available.
That's right.
Yeah. So we wouldn't see them.
Correct.
Yeah. So it's a good point that everybody needs to remember. And so, anything that you use in the patients, sedation medications, whether they're local or PO, local anesthetics, pain medications, all these things can interact with other drugs the patient is taking, other prescriptions. And so it's really incumbent upon us to look up medication interactions. It's so easy to do now. You can just put it Google it online, and it'll show you exactly, for each medication what the interactions are.
Right.
And
that way, Jay, I remember reading one time, the injection of local anesthetic is a serious surgical intervention. What a great phrase that was, because it just does not work orally. It works systemically. Right. Okay. Yep. Yes, it does help our patients get numb, but it affects systemically.
Yeah.
All right.
Yeah. I mean, especially when you see someone's heart rate go up when you use lidocaine with epinephrine.
And, we've said this before in our other talks. The bottom line is all of your package inserts out there, our colleagues, look up warnings underneath that. You've got to be prepared for medical emergencies. That is a medical legal binding document right there.
Yeah.
All right.
Yeah. You can't go to court and say, "Oh, I didn't know."
Yeah.
Yeah. Yeah. You got to know about everything that you're giving the patient.
That's correct.
All right. So our first drug is something called Zavzpret, which is a Zavegapant.
Zavegapant. That's right.
And this is a calcium gene related peptide receptor antagonist that's used for treating acute migraine. So it's not for migraine prevention, but it is for acute migraines. And it's been shown through the studies that this drug seems to be effective much faster than some of the other drugs that are on the market in relieving the headaches, the photophobia, the nausea, the sensitivity to sound. And
Think about it, Jay. Think about the delivery system. It's a
Yeah.
nasal spray. I mean, it's
Yeah.
right there. In about 6 seconds, it's already affected the brain and helping these
Yeah.
patients
Yeah,
with
for
their
sure.
migraine.
Yeah. And as someone who suffers from migraines, I know, luckily mine are not as bad as they used to be when I was young,
Right.
but it's not fun. So Zavpret has been shown to reduce or eliminate these symptoms within anywhere from 30 minutes to 2 hours,
Yes.
and allow people to go back to normal functioning sometimes within that time period even. Some people, I know people that get migraines that are out of commission for 2 days. And this is a way that a new drug that can help them recover a little quicker. So it's what it is a calcitonin gene related peptide receptor antagonist, and
Right.
CGRP is a clinical chemical messenger that is responsible for causing the pain and some of the other symptoms that you see in nausea. And
Right.
so by inhibiting those receptors, that seems to reduce the migraine pain and other symptoms. But they're not sure exactly how it works. This drug is a little different from some of the other migraine drugs in that it only can be taken once in a 24-hour period. Okay, so you just do this one spray. It's a single dose spray, one spray every 24 hours, and you can do it 8 sprays in 30 days. So if people have recurrent acute migraines, they can use it more than a few times during the month. But the usual side effects from this drug are very similar to the other migraine drugs, which is kind of a funny taste in your mouth, sometimes nausea, sometimes just nasal discomfort. In this case, because of the nasal spray, nausea and vomiting are kind of the main things, and just a kind of a queasy feeling in your stomach. But it can also have some serious side effects, which are didn't see any anaphylaxis, but they did see some pretty serious allergic reactions, and including swelling of the face, the tongue, the airway, that were quite significant. So the take home for us is that if you have a patient who has migraines and they are using this drug, they may have one of those severe allergic reactions. So you got to be prepared if they need to use it while they're in your office.
So basically, they could have a drug-induced angioedema.
Well, it's almost like an anaphylactic reaction, except that it really affects the face and airway and not necessarily the whole body. But the approval was basically based on mostly on a study that was published in Lancet last month, which showed that 40% of patients who used Zavzpret had a significant improvement in their symptoms and their headache, compared to only 31 in placebo. Now, it's interesting, 31% of patients who took the placebo got better. This is only 10% improvement, but I guess still 40% is 40%, right?
That's right.
Yeah, that's better than a lot of the drugs, because I know I tried probably 3 or 4 of them until I found one that worked for me. All right, so our next drug is, we talked about all those things. Next one is Daybue, or Daybue, however you want to pronounce it. Yeah,
trofinetide.
So this is an orphan drug for a very rare syndrome called Rett syndrome.
Right.
Okay, and so it's a synthetic analog of the terminal amino tripeptide on the insulin-like growth factor 1 receptor. And so this terminal peptide is glycine proline glutamate. And in patients who have Rett syndrome, they seem to be deficient in it. So this is basically a synthetic version of the naturally occurring drug that helps reduce the inflammation and support the synaptic function in the central nervous system, and will help a lot of the symptoms in patients that have Rett syndrome who are 2 years old and older. So it's a interesting disease.
Yes.
It's due to a mutation on a drug called the MECP2 gene, which regulates gene expression, and it's on the X chromosome. So it's seen more frequently in females between 6 and 18 months with the onset. So what it manifests with is kind of a delay in brain function, brain development, and a lot of these kids, they have trouble developing fine motor skills. They lose some of their gross motor skills, some of their communication skills. They may also have seizures, which is a big prognostic factor on how they're going to do. And these patients usually live into their 40s or 50s, and they usually succumb to seizures, pneumonia, malnutrition, or accidents. And the number of seizures they have, how many seizures they have, let's say in a week, a month, a year, the more seizures they have, the more likely they're going to pass at a younger age.
And think about it, Jay. They're coming to the dentist also.
They are.
Okay.
Yep.
So we got a couple of issues.
So now you know what Rett syndrome is.
Right.
If you didn't learn about it in dental school. And I don't think we even learned about it in med school. I can't remember. Maybe we did. It was a long time ago, so I forgot.
Oh, yeah.
And it's a twice daily oral dose. And really the major side effects have to do with GI upset and sometimes weight loss. So it's a relatively safe drug for most patients. So yeah, it's administered twice a day, and diarrhea and weight loss. Okay. The next one is Rezzayo, and this is rezafungin. So as you would probably speculate, this is an antifungal, and it comes in a powder form. It's reconstituted with saline, and this is used for treating severe cases of candidiasis, what we call candinemia, which means that not only has the candida invaded mucous membranes, but it's also detectable in the patient's blood, and obviously the patients are much sicker.
Very septic.
So this is not a first line drug. No. It's only used in patients who haven't improved or can't take some of the other standard drugs, which are things like vancomycin amphotericin, and as we call it in medical school, amphotericin, and some of the azole antifungals like fluconazole and ketoconazole, which you may be familiar with. And so that's when Rezzayo is used, is when you can't use any other drugs. And this is the fourth drug in a class of drugs known as echinocardin antifungals. The first one was introduced in 2010. It was called capsofungin. And what it does is it interrupts the development or the formation of the cell wall in the yeast in the candida. So that's how it works. So the biggest issues with this are hypersensitivity reactions. It's probably on the next slide, right? Yeah.
There we go.
Okay. So hypersensitivity reactions, including flushing, sensation of warmth, urticaria, hypersensitivity, and actually photosensitivity, and sometimes abnormal liver function tests are seen.
Look at that. Look at the third bullet point, Jay. I mean, the safety has not been established after 4 weekly doses.
Yeah. And it's interesting that it's only given.
Must really be significant in these patients. Okay.
Yeah, and it's interesting. It must have a really tremendous long half-life because it's administered once a week.
Yes.
For a severe infection. Normally we're giving antibiotics 2, 3, 4 times a day, and this drug is so effective against the fungus cell walls that you only have to dose the patient once a week, which is pretty interesting.
Let's say these people are getting some form, they're getting treatment, and then they wind up needing your services. You got to do an extraction. Do you give these patients antibiotics afterwards or not? Because the common adverse reaction here is diarrhea already.
Mm-hmm. Yeah.
All right. So the last thing you want to do is worry about inflaming that. And now you wind up with something like a C. diff situation.
Yeah. Yeah. On top of the
candidemia.
Yeah.
Yes.
Yeah. One thing you definitely don't want.
Yeah. So, I mean, if they come in, like, I'm taking this injection for what, I mean, these are going to be sick patients.
Yeah. I mean, they're basically going to be hospitalized.
Yeah.
So you probably won't see them in the office, but, you know, someone who
but somebody
has been on it recently,
somebody that's been discharged from the hospital, Jay, that could be a different story.
Yeah,
you
and
know?
they have, as we mentioned, they have a higher risk of having hypersensitivity reactions. So you got to be careful with everything you give them, and just like we talked about with the clindamycin, be prepared to handle a medical emergency in your office. So the next drug we're going to talk about is another orphan drug. See, they're mushrooming. There's so many of them now, and this is called Zynyz. And as you can tell by the name, retifanlimab, it is a monoclonal antibody drug.
Yep.
And notice it's got that suffix, DLWR. And so, John, what does that mean?
It means absolutely nothing, Jay.
Normally when you see that,
we talked about that. I mean, you're like, oh, wait, is that something else I need to know about the drug? No, that's just a distinctive mark that the FDA gave that generic name.
Yeah. So what's interesting is that normally you see that when it's a biosimilar. So there's another brand of this drug, but this is just a little different. That it's still called the same thing, but they give this prefix of or suffix of 4 random letters. Yeah. So I'm not sure why this is, because this is a first-in-class drug.
Yes.
It is, and it's used to treat a very rare skin cancer known as Merkel cell carcinoma.
And you know, we've had some of those programmed death receptors already.
Yeah, so that's what this is. It blocks the PD-1 programmed death receptor on T cells. And so what happens?
Well, Jay, what happened when we had that other one? It was if you remember, a mantle cell carcinoma.
Yeah.
And that was also a dedicated death receptor as well, too.
Right. So what happens with Merkel cell carcinoma is the PD-1 protein that's on immune cells, on T cells, interacts with a antigen that is on the surface of these cancerous cells called PD-L1. And what the PD-L1 receptor, when they bind, it tells the immune cell, no, this is a healthy cell, leave it alone, that you don't need to destroy me. And so by blocking that on the T cells, then it kind of removes the brakes on the system so that the immune system can work more effectively to attack the cancer. So pretty interesting how that works. So Merkel cell is a pretty rare aggressive skin cancer that usually you see in sun-exposed areas like the head, the neck, also on the arms, on the where else can you find on skin, heads, neck, and arms.
the back as well.
Yeah, exactly. And it tends to be highly metastatic. And in fact, the 5-year survival for patients who have metastatic Merkel cell carcinoma is only 14%, and that's with aggressive treatment. So hopefully this drug will improve those odds. But what's interesting about the Merkel cell carcinoma is the Merkel cell is it's a fairly rare cell that's seen usually in the basal layer of the epidermis, and it seems to be located around hair follicles. So they think it has something to do with sensitivity of kind of a touch sensation. But the Merkel cell carcinoma actually develops in the dermis, not in the epidermis. So what they think is that it's due to a pluripotential stem cell that divides into the Merkel cell, becomes a Merkel cell that becomes cancerous. And that's why it's got a lot of features that are similar.
Yeah. And you know, Jay, too, so the 4 areas, back, arms, neck, scalp, for both Merkel cell as well as melanoma. Because again, if you see any type of growth, and with us, we look at head and neck stuff. Okay. That's what we do as dentists. Okay. So if you see some type of growth that just doesn't look right, you see something, say something.
Okay? Yeah. It's purplish. It's maybe a centimeter in diameter. It looks kind of almost like a blood blister.
Yeah.
Kind of purplish, reddish, well circumscribed. But it's dangerous. It's a very highly metastatic tumor that does not have great long-term survival. This drug is, it's not known if this is effective or safe to use in kids. So it's only used in adults 18 years and over. Because it's messing with the immune system, and what it's doing is it's blocking that interaction with the PD-L1 receptors, which can be on normal cells. Zynyz can actually cause your immune system to attack your own healthy cells. And the list of side effects of this drug are crazy. Cough, shortness of breath, chest pain, diarrhea, bloody stool, abdominal pain and tenderness, jaundice, bloody urine, bleeding more than normal, headaches that won't go away, eye sensitivity to light, sweating, rapid heartbeat, weight gain or weight loss, frequent urination, hair loss, constipation, voice getting deeper, decrease in urine output, blood in the urine, swelling of ankles, rashes, itching, skin peeling, painful sores in the mouth, chest pain, irregular heartbeat, changes in mood and behavior, tingling and numbness of the arms or legs, double vision, blurry vision, and muscle pain or weakness, and low blood cell count. And I skipped about half of them.
Yeah.
So this, for hopefully, these side effects are fairly rare, and the benefits will outweigh the risk. And this was another drug that was fast-tracked because it was shown to be effective against this rare disease of Merkel cell carcinoma.
Yeah.
So, continued approval will be based on further studies that prove its effectiveness and low incidence of side effects. Okay, I think we're on our last drug, and so this is another
Joenja.
It's another orphan drug. Excuse me. Which is, as you can tell from the end of the name, the IB on the end of the name is an inhibitor of or modulator of the immune system. And so this is used for treatment of a rare disease that affects the immune system called activated phosphoinositase 3 kinase delta syndrome, or APDS is what we'll call it for now.
Yes.
And it's a primary immunodeficiency. And what it does is it increases the patient's susceptibility to infections like ear infections, sinus infections, upper lower respiratory infections, and also autoimmune inflammatory syndromes. And the way this works, John, I'll let you talk and say something.
No, you're perfect, because it talks about the infections located in the ears, sinuses, and it could also be in the mucous membranes of the mouth as well too. And they have a higher risk for cancers, specifically lymphoma. Yeah.
So this disease comes about because of a mutation, either the PIK3CD or the PIK3R1 genes, which basically leads to a deficiency of the kinase. And so what this drug does, it's again a new class of drugs called phosphoinositase 3 kinase delta inhibitor. So it works by inhibiting a cellular messenger that interferes with the normal function and development of the immune cells. Yes. So the phosphoinositase 3 kinase delta inhibits when basically the activity is increased, or the amount that's produced is increased. That's what inhibits the immune cells, and this drug blocks that from happening. And it's a twice daily pill. Side effects are not all that bad. Headache, sinus inflammation, eczema, skin dryness, but you do want to make sure when patients are given this that they're not pregnant, because it can, it's been shown that it may have some effects on pregnancy. So that's that. That's all of our drugs for today, or for this month.
But go to the next slide.
If you insist. Oh, yeah.
Yeah,
there we go.
Yeah. I knew we had more on Joenja.
Yeah, I thought so. Yeah, we have like 2 or 3 slides on every drug. Yeah. But so here it is for everybody to copy down quickly. And hopefully you're all writing down the names of the drugs that we're talking about. These are all the drugs that were approved in March of 2023. So there were 5 of them, 5 or 6. And so that way you can go back and look them up yourselves now that you know what these drugs are. So big news.
Yes. Can you believe the FDA has just approved the first ever over-the-counter nasal spray for opioid overdose? And I don't have to explain what Narcan is to any dentist out there. I don't have to explain what opioid overdoses are. Yeah. But I do want to point out my last bullet point. More than 101,000 reported fatal overdoses in the last 12 months.
Wow. Yeah. It's
amazing.
Serious. I mean, it's better than it was at the peak of the opioid crisis, but the numbers are still staggering.
Oh, staggering. And of course, great time for me to put a plug in, Jay, for your course on dentallearning.net. Great opioid course for 3 hours of training. Yeah. And you're going to have to have that training, and Jay's course covers everything.
Yeah. And it covers all the topics that are required in all 50 states. Some states require, let's see, do we have a slide on that? No. I think we do at the end. Some states require 1 hour, some states 2, some 3, some don't have a requirement for opioid education. Although now there's a new federal mandate to get your DEA license or a permit or to renew it, you have to have 8 hours of opioid training. And it doesn't have to be one time. It's one time, and it can be multiple courses that add up to 8 hours. And if you've already taken a 3-hour course, then that counts.
And remember, now, if you buy this to keep this at your office, and should something happen, or outside the office as well, too, remember, as dentists, you have the opportunity to save a life. And when you peel the nasal spray out of the pill pack, don't do this. Don't prime it. It's ready to go.
Yeah.
Okay?
Just pump. Right. Yeah. Just spray it and go one nostril
and hit. Okay.
Yeah. And you can give a repeat dose, just like with regular Narcan, naloxone. But the idea here is this is going to bring having naloxone to the masses, because a lot of people who have family members and friends with opiate use disorder, they are uncomfortable giving an injection, and so this is going to be a big benefit for them. They don't know yet how much it's going to cost. So hopefully it won't be something ridiculous. Maybe, $50 or maybe even less, although it could be up to $100, who knows?
Jay, the way I see eventually in our emergency kits, everything's going to be a nasal spray. Mm-hmm. All right. For some type of emergency medication. All right. Because,
you get rapid absorption through the nasal mucosa.
Absolutely. So because, a lot of dentists don't know how to use an epinephrine auto injector, but it's easy to use a nasal spray.
Yeah.
All right.
Exactly.
And if you don't know how to use an auto injector, as soon as yours expires, that's right. Either ask the company for a training device, or if you've got one expired already, go practice on a piece of fruit.
Yeah.
All right.
Yeah. Don't use it on yourself.
No, don't use it on yourself. But because in anaphylaxis, you don't have much time.
Right. Exactly. You gotta react very quickly once you recognize.
And of course, same thing with opioid overdose as well, too, Jay. I mean, you got respiratory depression, and it's not going to get better until you use that nasal spray.
Yeah, and that's one of the biggest. In addition to being extremely lethargic,
Yeah.
The respiratory depression is what causes death of a
Correct.
lot of opioid
Quickly.
patients. They obstruct their airway, they stop breathing, that leads to bradycardia, that leads to flatline, and then they're dead.
That's
And
right.
so if you can intervene rapidly and right then and there, this is a great drug to have handy.
And
I've got some drugs I keep in my car, and I also
absolutely.
have an
Same
AED,
here.
and I also have
And
an AED in my
I
car.
do too. And look, everyone, I mean, if you have to use this, guess what you do in the very beginning? Call 911.
Yeah.
Okay.
Or have someone
So
call. Yeah.
have someone call. So you know you're about to use a nasal spray, call 911.
Yeah.
All right.
Yeah. And remember to, again, check your ABCs, airway, breathing, circulation.
And the reason being, Jay, because they can resedate on the fentanyl, having a longer half-life than the Narcan. Okay.
Yeah.
So help is on the way when you call 911. You have backup coming.
Yeah.
Okay.
Yeah. You always, of course, you always want backup for a situation like this. So our medical emergency of the month is something that's fairly common.
Yes, it is.
So it's asthma.
Asthma.
So what's happening in asthma is that it's a reactive disease in which the airways narrow and swell. They may produce more mucus, and it makes breathing much more difficult, triggering coughing. The patient will have a wheezing sound when they exhale. So it's not an inspiratory wheeze, it's an expiratory wheeze, which makes the patient shorter breath. And so some of the other things they may feel is chest tightness and trouble sleeping because of shortness of breath. But if you have an attack in your office, you're going to see the wheezing. You're going to see the struggling to breathe. You may see a drop in their oxygen saturation. And you've got to get them, you've got to treat this right away, or it can progress to the point where the patient just, as they say in your neck of the woods, plum tuckers out and goes into respiratory arrest because they just can't. They're putting so much work into breathing. They've got sternal retractions, and you can really tell they're struggling, and then they just poop out.
And Jay, something very important about wheezing, and that everybody should take note here, is that if wheezing comes to an end, more than likely there's no more breathing going on either.
Yeah.
All right. That means this asthmatic attack is significant.
Yeah. It's on the brink of disaster.
Correct.
Yeah.
So wheezing is an early sign that, hey, we've got to get things under control.
Yeah.
When the wheezing goes away, you're in trouble.
Yeah. Coughing or wheezing are the first signs. And of course, most of the patients are going to know they have asthma.
Yes.
And many of them will carry their inhaler with you, but it's, again, as we talk about in our DOMES video, it's something that you need to have in your drug emergency kit. So there are a lot of things that can trigger asthma.
A lot of triggers.
Yeah. I have a lot of patients say exercise induces asthma. Spring, they get asthma from different allergens, pollen, dust mites.
Yes.
Sometimes cold air will do it. And in the setting of the dental office, stress can sometimes bring it on.
And certain medications right there, beta blockers, aspirin, the NSAIDs.
So you always want to ask your patients when they tell you they have asthma, you want to find out what their triggers are.
Yes.
Very, very important to ask them so that, let's say, mostly it's set off by pollen and that's it. Lower risk of them having stress in your office being an asthma trigger. Than if they say, when I get stressed, I have an asthma attack frequently. So those are the patients you got to be extra vigilant with.
So Jay, we just got through talking about Narcan. So as practitioners, we're trying to all move away from opioids and relying on NSAIDs. So like you said, those patients with asthma, you definitely need to ask them, do you have an issue taking an NSAID? Does it trigger an asthmatic attack?
Yeah.
So that's very important that you need to document that in your notes as well too. And on the front of the chart, or if you're electronic record, I mean, it should light up saying, Patient has asthma,
Yeah.
cannot take NSAIDs.
Yeah, and a lot of these asthma patients that react to NSAIDs, they also have, as part of their allergic triad or asthma triad, nasal polyps.
Polyps
is another thing that we see. Nasal polyps, asthma, and sensitivity to actually asthma attacks being set off by nonsteroidals. So
Samter's syndrome.
Yeah. So asthma is pretty common. As you can see here, 25 million people plus in the US alone have asthma. That's adults and children. And 10 million asthma attacks occurred in 2020, accounting for over 4,000 deaths.
Jay, okay, so again, all of the practitioners listening to us need to look at that last number. Over 4,100 people died due to asthma. All right.
Yeah, I had a teacher in high school. In fact, she was our AP English teacher and college counselor. Everybody loved her. And like the week before graduation, she had an asthma attack, used her inhaler. I'm not sure if she had an EpiPen too, but she died from an asthma attack. And she
probably wound up having a refractory.
Probably in her, of course, back when we were in high school, everybody looked old, but she was probably in her late 30s, early 40s, and otherwise healthy. And she had a fatal asthma attack. So
she probably had a refractory attack of asthma that the albuterol didn't respond to.
Yeah, exactly.
And the thing about it, Jay, if that patient comes in and says, either exercise induced or stress induced, before you treat that patient, have them bring their albuterol inhaler.
Yeah.
In your waiting room, have them take 2 puffs. So let somebody witness that. Okay.
Yeah.
All right?
We always do that in the office. We tell them to bring their own inhaler.
25 years, Jay, doing that. I've never had an asthmatic attack.
Yeah.
Okay? Never.
Yeah.
Right? You're older than me. You can speak.
Not by much. We have, of course, an inhaler in our office, and we have these spacers.
Yes.
And we have disposable spacers. So if a patient doesn't bring their own inhaler, or if we have to use our own inhaler when the patient is under anesthesia, we use it with the spacer, so it doesn't contaminate our inhaler. Well, so you might want to have some check into those too.
By giving that albuterol puffs, you activate the beta-2 sympathomimetic system, it bronchodilates them, and now you have a better chance of reducing your medical emergency. Okay, I said reduce. I didn't say prevent.
Right.
All right. And we're never going to be able to 100% prevent medical emergencies.
Exactly.
Right?
Exactly.
And I hope there's no lecturer out there saying that, because you can reduce your chance,
right?
But you're still going to have a medical emergency in your practice.
Yeah. And so that brings us to our algorithm,
to
our medical emergency for asthma. And you can get this algorithm if you subscribe to our DOME series, Dental Office Emergency Simulations, which is also on Dental Learning LLC. Dentallearning.net.
There you go.
So let's go through this algorithm. You'll notice on the upper right, number 1, all emergencies, is remain calm as much as you can.
Take a big, deep breath when this happens. Okay.
Yeah.
All right. Because you got to be the team leader. You're the reactor. Okay. Yeah. All right. Everybody's looking towards you. You can't
recognize the problem and direct your team. You are the head of the team. You're your coach. So obviously, if a patient's having an asthmatic attack, you're going to assess how severe it is, and you're going to stop whatever you're doing. If you have, if you're doing an extraction and the patient's bleeding, you may have to put some gauze over the extraction site so the patient doesn't start choking on blood to make things even worse. What we always do with our packs, with our patients, especially post sedation until they're awake, is we roll up a 4x4 inside another 4x4 and have a tail that hangs out of the mouth. That way we know that it's exactly where we put it.
We do the same thing. Yeah. All right. And always have that tail hanging out.
Yeah. So once you've identified the problem and stop your treatment, you're of course going to initiate your medical emergency plan that you have prepared for your office, right? And you're going to put the patient in the most comfortable position for them, which generally is not laying supine, but sitting up.
Making them comfortable.
Yeah, exactly. And then, of course, you go through your ABCs. And in ACLS, or I think in BLS now, it's actually been changed to CAB. So you always check for circulation first. Now, obviously, if the patient's breathing, they're going to, their heart's going to be pumping and they're going to have a pulse. But you want to make sure that airway is open.
Well, these patients are going to be struggling to breathe right
Yeah.
now. They're going to be wheezing. It's going to be some animated moments in your operatory right now. And hopefully, as Jay's indicated, you already initiated your medical emergency plan, which means someone's already retrieved the emergency drug kit.
Yeah.
Okay.
Yep.
All right.
Yep. Or
in that drug
or the
kit,
patient has left out their inhaler on your counter so that if they need it, you can grab it, and you give them not just 2 puffs, but up to 4 of albuterol, which is kind of the first line of drug to give.
So make sure they're upright and they're in a position where they can get a good puff and get that albuterol into their lungs.
Yeah, quickly. And that's where the spacer really helps, because it helps.
Oh, absolutely.
Mist makes more of a mist. And so it gets to the back of their throat and down their airway. Make sure you put them on oxygen, usually, nasal oxygen. But if you have a full face mask, that's not a bad idea too, because that's going to give a higher concentration of oxygen. So even when you have with a nasal cannula, if you have it turned up, I think to 8 liters, I think it only raises the oxygen concentration by about 10%.
That's
whereas
right.
a full face mask, it's 20%. And a non-rebreather, even
you
better.
have a pulse oximeter in the office, make sure you have that on the patient as well, too.
Minimum. And if you have an automatic blood pressure cuff, put that on the patient. But
somebody should be documenting all of this as well, too.
We put everybody on a pulse oximeter, whether or not they are they have any medical issues.
Absolutely.
Just so we have that monitor going.
That's
and
right.
Our routine in our office, anyone over 55 now gets put on full monitors, even if it's a local. Just because
we've been doing that.
We don't want to be surprised.
Like I just said earlier in our talk, the intervention of local anesthetic is a serious surgical intervention. All right.
And obviously any age if they have a known cardiac history.
So at any given time, I can give that local anesthetic, and now I have a medical emergency. Well, I've already got my monitors on. I got my pulse ox on. We can find out what's going on with the blood pressure.
Yeah.
So Joe, let's just say, okay, we give 4 puffs of our albuterol and it's not relieved. Okay.
If it is relieved, then, algorithm obviously stops, as you can see there on the left.
Right.
And you may have already called 911. So if they come and the patient's fine, they'll assess the patient. If the patient's fine, they'll leave. But you do want to let the patient's physician know what happened and let them know what kind of condition there is. They may want to change their asthma medication or add another asthma medication.
Another adjunctive medication like Singulate or something else.
Yeah.
But what
do we do if it doesn't relieve it? What are our next steps?
And we go back to what happened to your teacher right there. Okay. And so this wound up being a refractory case. We hope you've already called 911. We're going to repeat the albuterol. And if that patient is still struggling, or if they stop wheezing, okay, we're in a serious bronchospasm or asthmatic attack.
We're going to have to mechanically ventilate them with their bag valve.
Right. And now it's time to use epinephrine. Okay. Now it's time to use your EpiPen. And hopefully you do have an EpiPen, or if you got the ampule, you know how to draw it up correctly and to give this kind of medication as well too.
Yeah. Either EpiPen or just the preloaded syringe, which is a 10 cc or 3 cc syringe that you just give the whole thing. If you have the little vials, it's only 0.3 milliliters. So it's not much because it's highly concentrated, 1 to 1,000. And just like you do with anaphylaxis, you give, if the albuterol is not working after giving it twice, especially after 8 puffs, get the epinephrine. In fact, your assistants should be getting the epinephrine ready just in case. You always want to be 2 steps ahead.
Well, but I mean, Jay, it goes back also on that. Now, I mean, you got to know, do you have a 1 to 1,000 concentration, or do you have a 1 to 10,000 concentration?
Yeah.
Because like you said, if you've got a 1 to
Yeah,
10,000, you can just draw it up in a 3 cc syringe and give
Right.
the 3 cc's. You're
Right.
good.
Yeah. Or,
Okay.
or you'll have a pre-filled syringe with 10 cc's and you give 3. Or if you're using, if the little ampule, which is a little glass ampule where you break off the top, that's when you use 0.3 out of that 1 milliliter,
out of that
as your initial
syringe.
dose. Yeah,
that's right.
Yeah,
that's
but I would recommend using at least a 21 gauge needle. You don't want to use a fine needle and have it bend on you when you're trying to jab it into the patient's thigh, especially if you're going through clothing.
And Jay, the other thing is, I like how you said, go ahead and have this drawn up and ready, okay? Because trust me, please, someone try to draw up out of a ampule or a vial from a tuberculin syringe, how slow it is.
Yeah,
that's
why, bigger needle, even an 18. And remember, everyone's going to be anxious and nervous. And then, your staff may be shaking. It's going to be harder for them to draw it up quickly if they need it. So you want to have it ready. You want to be prepared.
And look, and there's a good chance you're going to have a patient not breathing. So you're going to have a tight bag valve mask seal on this patient.
Yeah. Because
as we say in them.
Yeah. So as we say in the profession, shit can happen fast and it can go downhill fast.
All right. So Jay, on our great 2-hour webinar that we did of patient dies, medical emergency gone bad, you and I were talking about
did we have
being expert.
Oh, there we go.
Witnesses. Yeah.
Yeah.
And, this is one of those cases, you said we get a nice revenue on the side doing this. Well, I got called about an asthmatic case. A patient died in a dental office. And I asked the person calling me, if I wanted to be the defense expert witness. And I said, did the dentist have albuterol? Guess what the answer was?
I can guess. Yeah.
No. Yeah. And guess what the core 8 drugs are in all dental offices? Jay, you know what? I could have easily taken that case. It would have gone nowhere. I told them, I said, I'm going to respectfully decline because this is going to go on the opposite side.
Yeah. There's no way you can win. It's indefensible.
I said, go ahead and try to settle this the best you can.
Yeah.
All right.
Yep. So, and in our videos, of course, and actually in the patient dies in your office webinar.
It's coming up May 5th as well, too.
May 5th. Yeah.
Yeah.
We list all the drugs that you need to have in your basic emergency kit again. The other thing we mentioned was PharmaDocs, which is now on dentallearning.net. And as you can see, we have 15 modules of all different categories of drugs. And we're going to be adding to this as to subscribers as new drugs come out. And you can see the list here of first modules 1 to 6, and then 7 to 15 goes through the other classes of medicines, as well as discussing drug-to-drug interactions, and including, if your patient's already taking something, what can you give them?
Yeah.
What can you not give them? All right. So only on dentallearning.net.
Right there, Jay. I just want to stress this to everybody. When you do find a pharmacology lecture, it's probably going to be on one subject matter. And of course, that means you got to shut your office down, go find that lecture, go travel. And, Jay, the studies show at the end of the day, you're going to forget about 66% of that lecture.
Yeah.
Okay.
But imagine being able to go back and review as many times as you
We're
want.
talking about go back 24/7, 365.
Mm-hmm.
You can review this. You're not going to forget.
Yeah.
All right. You're going to be able to review this anytime you want to. You don't have to travel, no airline ticket, no hotel, no meals, no registration fees, no lost production at the office.
And you can take it at your own pace.
Yeah.
You
Take it at your own pace.
And you get CE credits.
You get CE credit. That's right. Yeah. And I'm telling you, dentallearning.net has so well done this.
Yeah,
I mean,
it's an amazing job for us.
So professionally done. I mean, it's so impressive. And you're just going to learn so much because it's more than just pharmacology. Jay and I went ahead and got you updated on medically compromised patients, adverse drug reactions. We just cover so much, medical emergencies throughout it as well too. And so, and whether it be that or the domes video that Jay talked about, again, you have access to this 24/7 and you're not going to forget it.
Yeah. And these two courses go hand in hand. So that's our domes, 5 separate modules, again on dentallearning.net. And this is the opioid course that John was referring to that I did. As I said, it covers all the topics for every state in the country. And it's 3 hours. So it covers if you need 1, 2, or 3. Now, California, you have to be a registered provider. And we're in the process of actually setting up a separate course for California that's 2 hours that meets the California requirements. And what's interesting is you have to, I didn't have to change any content. I just had to change the title of the slide to make it and change it on my outline specifically for California to make it eligible. So, so California,
so everybody take this course. All right. I mean, Jay's going to give you a great course every time. Oh, look, next PharmaDocs.
Look, we're going to be back again. We're going to be back next month, May 12th, which is the second Friday of the month. And we will be covering not only the medical emergency of the month, but we're also going to talk about the drugs that were approved this month by the FDA.
And there have already been some approved.
Yeah,
right?
Exactly.
And any exciting news related to pharmacology, we're going to bring it to you. All right? I mean, you're going to be caught up if you follow the PharmaDocs and get PharmaDent. All right. You'll never be without. I promise you that, because you're talking about dentist to dentist.
Yeah.
Right? We're in the trenches like you are every day.
You can count on us. All right. So that will bid you adieu until next month.
Goodbye, everybody. Thank you.